So it's great. It's great that, you know, I've been associated with Headway in a very informal ways. You know, I have some of my patients looked after by the teams. You know, some of them are some of my favorite patients, if you are allowed to have favorite patients. And of course, you know, I have visited lots of the charity shops. You know, there is no doubt about this. So so who am I? Just to break it with the ice. So I'm a clinical neurologist. You know, clinical neurologist is I'm a consultant neurologist. I go to work, I go to the hospital, I see people, and most of the neurology ward is acute injuries, but most of my work and most of the neurologist's work is doing outpatient clinics. So we see people after the injury, and the injuries could be from, you know, actually they don't necessarily have to have an injury. They can be from brain tumors to epilepsy, to multiple sclerosis, to headaches, to so on. And with Afagh, the same time as I'm a clinical neurologist, I also have, I'm employed, my employer is the university. So I'm what we call an academic neurologist. And, you know, that means that half of my salary and half of my responsibilities is to the university to do research, to teach medical students, and the other half is to the hospital to look after people through the NHS. And as a neurologist, obviously, I deal with the brain. I deal with the brain and the spinal cord. And when COVID happened, you know, of course, life has changed and has changed forever. And my work life has changed, like lots of your work life has changed. So in addition to all the research I was doing with other neurological diseases, all of a sudden, the impact of COVID to my patients and the impact of COVID to the hospital has become a priority. I see lots of people with multiple sclerosis, lots of people with MS, and immediately, because lots of people that have medicines that lower the immune system, there was a bit of a panic, and what's happening, what is going to happen with an infection that that might be made worse by the treatments. So with Afagh, that will give a presentation later on, we linked, there is a national registry of people with multiple sclerosis in the UK, so patients with multiple sclerosis, with the MS Society and another charity. We set up a study to try to see the effect of COVID to people with multiple sclerosis. And Afagh will talk about some of this work, and particularly, of course, about the long COVID. So what I'm going to do is I'm just going to give a relatively brief, it might not be 40 minutes together with Afagh, or you might find that, as you can see, that I talk too much and it will be an hour and a half. It will be shorter, I think, than 40 minutes, of a brief introduction, how I understand COVID, or how some people understand COVID, accepting that there are changes that are happening long COVID, that there are changes that are happening, every week something new is happening, some other research comes along with new data. So it is great, and I think, it's great to record this meeting for the people that have not been able to listen. But the only problem with the recording of these meetings that you might find that in a month's time, something that I think is right now, we might find in a month's time, somebody has come along with some new evidence and change. So provided we have this this warning, so, and then you can say, do I want to hear your individual news, your individual opinion, and tells me, how did she find you? What about if you are you could see that every so often, every time you open the newspapers or the television, you have two scientists or two doctors, they disagree and they have a bit of a fight. So then you can say, what about if you have your extreme views on the left or the right? So I thought to try to do it a bit more balanced, in science, there are a number of journals, this is where the scientists and the doctors they write their findings. And probably the two most famous journals in science, one of them is called Nature and the other one is called Science. So I thought, why don't I give you a bit of a description of long COVID, of the major problems that we have with long COVID, as it was portrayed in a relatively recent review of long COVID there. And of course, I will have my personal views which way things might go or might not go, but accepting that nobody has the right answer. Is that all right? Is that going okay? So what I'm going to do, I'm going to throw a few slides. We were hoping, actually, in addition to the two of us, we're hoping that we had a psychologist that will talk about the evidence that is slowly accumulating, how psychology might be used to support people with long COVID. Sadly, and I don't think that I have said this to Tamsin, a member of your family had a bad accident, so she has not been able to work on this. So sadly, you will hear me and Afagh. So with this very long-winded introduction, I apologize. I share my screen, but Tamsin will allow me to share my screen because at the moment she has disabled me. So Tamsin, what you have to do is you have to go, I think, to the settings, and you say allow Nikos to share his screen.
Yeah,
I've
made
okay.
you co-host, Nikos.
Oh, fantastic.
Now you should be able to.
Fiona has sorted out. I can see Tamsin is having a bit of a panic there. What's happening here? Now, but are you showing the right thing? Oof, I don't know what you're saying. This is the embarrassing thing.
We're seeing the Zoom screen, but I think, can everyone else see the screen okay?
You shouldn't be seeing the Zoom screen. Excellent.
Yes,
So let's stop sharing
browser,
again.
I think, Nikos.
That's embarrassing. This is, what else will you see? This is my fear. This is my fear. Okay, we'll try again. Let's try this one now. What do you think of that? That's a bit better, isn't it?
Yeah.
Fantastic. We're saved. Yes. Tell me what you see now.
Yes, I think, can everyone else? Yep.
Long COVID.
Yep, long COVID screen.
Fantastic. Now, how am I going to do it? I'm going to do it, having done this 50 times over the last year, it's still every time I'm struggling. It's probably my age and my early cognitive decline. So, as I said, this is who I am. And one of the funny things that I only realized last week is there was a Twitter who has mentioned Elisa Perego. I never heard of Elisa Perego, but sometime in May last year says, oh, these symptoms are lasting for long, and it appears to be as if we have COVID and long COVID. And she has used this hashtag long COVID, and since then we're calling it, long COVID. And I think it's amazing that you come up with a name without thinking that she's making a major contribution to how we deal with the disease, and has become the name of the disease, at least in the UK and some other countries. So, as I said, there are lots of ways of, and lots of opinions about the long COVID and what is causing it, what's the effect, and what we know and we don't know. This is based on a recent feature article in Nature. Now, what about the symptoms? The symptoms are extremely variable. So we have read about, and you have possibly, you have seen on TV, you have listened on the radio, and you might have come across people that they say, I feel very tired. My thinking is not very clear. I seem to be all right. I got this infection. I was tested positive. I had a cough for a couple of weeks. I might have been to hospital or not, but then I had developed all the other symptoms. And because it is not like easy as a stroke, and the stroke is We know if the stroke, we have a particular artery that blocks the blood supply to a part of the brain, this is the symptoms you would expect. And I can, if you tell me, which artery of the brain is blocked, or I can see the scan, I can, with a bit of arrogancy, I can almost tell you the symptoms that the people are experiencing. So because it is not like a structural damage to a particular part of the body, we have now a combination of symptoms that we still do not understand, and we see them more frequently in people that have experienced COVID before, and if they persist for some time, we call it long COVID. But there is an effort, there has done a study, you can see here in 3,500 people in lots of different countries. They said, just tell us what symptoms do you have. And when they wrote down the list of the symptoms, they found 205 symptoms. So, there are some people who say that, look, I'm the age of 60, I never had hiccups, I developed COVID, and since then I have hiccups. So hiccups is not many people, I don't want to give you to stick that all hiccups can be a sign of long COVID. But the only way to understand what is related or what's not related is to say, tell us everything that you are experiencing. Then we can put them together. We can ask lots of other people. And if we find a trend, we can find what seems to be more common. And so once they collected these 205 symptoms, the other striking thing is that they found that on average, people have multiple symptoms. It is not like I only have a dry cough. I have a dry cough and I feel a bit tired and I have developed a numbness of my left hand. These are 3 symptoms. And on average of the people that they have responded to the long COVID questionnaires, they have said, they had 14 symptoms. Now, we have to take with a pinch of salt here, because this was done relatively early and in people that they were organized, and they have created some long COVID, Facebook groups and so on. And who joins a Facebook group? It's most likely that if you are affected much more than the average, if you think about it. So it is, when I say that, they have found, I didn't say anything, this is what they report on average, they have 14 symptoms. I have seen that in my clinical practice. You see many, many people that they are milder in terms of symptoms, and they could have had 2 symptoms or 3 symptoms. But because they were not devastated by those symptoms, possibly, they have not recorded them, they have not joined the Facebook group, and they have not said all the symptoms. So I think this is more likely to represent the most extreme part of the long COVID spectrum. And you could see that there are lots of different organ systems. There are some people that they will have breathing symptoms, from hoarse voice, I'm coughing, I feel breathless, I have a change in I wheeze, and this is the respiratory system. But there are other people that they have developed gastrointestinal, gut mobility, stomach problems. I developed abdominal pain. So they can be a different organ system. So it is not like you can easily tell with the evidence we have at the moment that long COVID, in your case, affecting the breathing system, in your case, affecting the brain. It could affect multiple different systems. But if you look at the combinations that have lasted for longer, and each symptom does not necessarily last the same period of time, it appears that the neurological, the thinking, the cognitive, the fatigue, the malaise, what they describe there, seem to be lasting for much longer. So it seems that although we keep hearing about COVID, being ventilated, ended up in ITU, it's clearly the breathing is the problem. Despite this, it is really the brain and type of symptoms that last significantly longer, even when the breathing seems to be improving. In the beginning, of course, we're thinking about ventilators. How can we buy ventilators from Mr. Dyson? Is he going to make us ventilators or not making us ventilators? And so nobody thought about the long-term problems. And relatively early, the Director General of the World Health Organization realized that, hey, we have all these people that they develop the disease, but they seem to be having problems for some time. So relatively early, the recommendation was made that we need to be aware that this is something that it is not going away 2 weeks after you had COVID. Some of the people, not everybody, some of the people will last for a bit longer. And as an indication of how serious this might be, if you think that the Americans, they have said, I'm going to give £1 billion trying to understand COVID, and who knows, it's very likely that they will increase this amount. And in a much more modest way, the UK said, let's pour some money into research to try to understand COVID. That means that, because of course the research is producing results, I don't know, in a year's time, most of the times, despite the incredible rate of research output we have had over the last year, people are anticipating that they will be with us for some time. Now, Afagh later on will tell us about the risk factors, that who gets COVID and what sort of numbers do we have. But it appears this is the weeks after the positive infection that you can see, there is, this is one of the studies, around 10%, around 15%, they seem to be having symptoms, even if they have recovered from the acute illness. And the critical question is, what is underlying, what is the biology of COVID? What is the biology of long COVID? Because of the COVID, we know it's all right. We have a virus, gets in, somehow we understood most of it. We understood that we can make the antibodies, we understood how we make vaccination, but why does it last for a bit longer? So people have tried to find, can I find the virus in the body of people that they have long COVID? And they have tried really, really hard. And it is really a minority. There are some reports that they are finding what appears to be the little green dots in the center. This is from a biopsy of the bowel. So, you wouldn't expect, why you would say the bowel? Obviously, this is an illness that people are having muscle aches. So it doesn't only go to the muscles. So we assume that, even the muscle being affected. So of the people that they have had COVID in the past, we know that if you do a biopsy in a small proportion of people, we have found something that suggests that even there might be some persistence of the virus in the bowels. There are many other studies that they have not found it. So I don't want you to get the impression that I'm definitely saying that long COVID is associated with the persistence of the virus. We know that some people, we do what is called the PCR test. The PCR is when you have an active infection. And some people, when we get infected, we have a positive PCR test. And a couple of weeks later, we have a negative PCR test. This is, I don't know, this is when we stop becoming infective. But there are some people that continue to be positive 2 months later. And we don't fully understand why some people are not clearing the virus. But there isn't a clear link between who is clearing the virus with who is getting long COVID. But I'm only saying that there is still a lot to be discussed. And only today I found another article that has not fully been published, but is going to come in the highest journal, that they said that although we didn't find the virus in the brain, there appeared to be some signal that some of the cells of the brain might have been affected by the virus. I don't know. So we still don't know the basic biology. And the other things that they have looked and said that, because in the beginning, who had COVID, we didn't know. We didn't have the testing. We're developing some cough and high fever, and we're feeling dreadful, and we say, stay at home. There wasn't anything to be tested. And then later on, but if you have become very, very unwell, you have to come into the hospital. So when you took and people have examined, 1,000 people that they have had COVID, and they have said, okay, let's examine how bad was your COVID. Did you need to be ventilated? Did you had a very high temperature? Did your blood tests were very, very abnormal? And so they didn't find that people with really bad acute COVID led to long COVID, to the chronic phase. So how bad you were affected in the beginning is not a prediction whether you will have long-term problems. So this is something that is puzzling. So we see it in medicine in a number of conditions, but whatever happens acutely is not necessarily linked with the long-term effect. And the story, of course, is that we know that if you get any illness, any viral illness, a proportion of us will recover very well a week later. A proportion will carry on having some symptoms for a bit longer. And although we are not talking about, most of us, we have not experienced chronic fatigue lasting months and months and years. But many of us, I think, we pick up a cold, and even 2 weeks later, 3 weeks later, 4 weeks later, you say, I haven't get rid of the cold. So, even if we haven't felt it ourselves, we have seen it from friends and family that sometimes, you pick up a virus and you are really struggling to fully recover. And the majority of times we have the full recovery. But on a number of viral infections and bacterial infections, other infections that affects the lung, the kidneys, the stomach, whatever, we know that a proportion of people will have symptoms that will last longer, and some people have reported sort of, around the 12%. And this is where the big debate starts with the chronic fatigue and the long COVID. Because essentially, we know in the long COVID, in the majority of times, we have a definite infection, and then we have some symptoms that have similarities with some of the symptoms with the ME, with the chronic fatigue syndrome. And it's very interesting that some organizations dealing with chronic fatigue syndrome, they're delighted because they say, at last there will be £1 billion invested by the American research. We might find what is causing our symptoms. So there are a number of efforts, and there are from genetic studies happening in chronic fatigue or ME, and they are linking now with the studies that people are undertaking both here in the UK and in America and other places to try to say, can we see the similarities? Can we find the answer to, in a way to both conditions? And what is at the moment we're doing, we're still in a bit of a, I have no idea what we're doing. We know that we need to look after people with long COVID. Clinics have started being set up. 69 clinics in the NHS has been set up. Most of the big towns, they have been given an amount of money to offer some support for people suffering from long COVID. From my experience here in the UK and in Nottingham and in other places that I have discussed, most people think that we're trying to cover the tip of the iceberg. Many people are not being referred to the clinic at one stage because they appointed 3 health professionals, a physiotherapist, a respiratory physician and psychologist says, can you set up a clinic? And all of a sudden they had these hundreds and thousands of referrals and say, I cannot see them that much. So there is a major issue. In terms of vaccinations, we don't think that vaccinations And there have been some studies about vaccinations. I was doing the on-call this week. I have had so many calls regarding headaches and that type of symptoms that happen after vaccination. So the majority of people said that vaccination did not make any difference to their long COVID symptoms. There are some people say that, oh, I'm feeling a bit better actually, and then equally there are some people that they say that actually I'm feeling a bit worse. So overall, we don't think that vaccination plays a major role modifying as a group the symptoms of long COVID. So I told you that I'm going to be very, very quick, and half an hour later I'm still talking, but I think I finished. So you'll be very glad that this is my general introduction of long COVID, how nature, one of the big pillars of scientific reporting and myself sees long COVID. There are tiny little, deviations of the theme, but I'll better ask Afagh to say, how did we try to investigate and what did we do on one of our studies? And with this, I will even try to, I don't know, how do I do that? Thank you very much. Stop sharing. Excellent.
Hello, everyone. Thank you for the introduction. Because I'm also, my background is neurology, and I'm a clinical research fellow in Nottingham and have been doing my PhD with Nikos, under Nikos' supervision. And my main research during the pandemic has been COVID in people with MS. And I'm not allowed to share my screen.
It's not allowing me to make you co-host for some reason.
Oh.
Do
you want to kick me out? And do we have a list of how many co-hosts can we have?
Oh, there we are. There we are.
You.
I should work now. Thank you.
Yes, hope you can see my screen. So I'm going to talk about long COVID risk factors in general, but I'm going to form the talk around the research we have done in long COVID, and this is the UK MS Register COVID-19 study. So first of all, we know that it's important to identify risk factors of long COVID. As Nikos mentioned, a large number of people have been affected by long COVID, no matter how we define it, really. And this is a huge burden on our healthcare system as we develop these rehabilitation services for patients. And if we identify the risk factors, it will enable us to tailor the rehabilitation services and develop individual pathways for post-COVID care, and that might help reduce the burden a little bit. So just a brief introduction to multiple sclerosis or MS, and I'm going to use this mainly to talk about risk factors in long COVID, but the findings could potentially be pertinent to other neurological conditions and other types of brain injury as well. So MS is an inflammation of the brain, spinal cord, and it can present with several different symptoms. And I just took this from the MS Society website, and in a glimpse, you probably can identify some symptoms like fatigue, pain, problems with memory and thinking, mental health problems that we see in long COVID as well. So there are similarities between MS symptoms and neurological symptoms of long COVID, and that's the case for many other neurological conditions, really. this study is ongoing, but I'm going to report our findings in 1 year throughout the pandemic. So since March 2020 to March 2021, that's 1 year. And we were able to recruit almost 8,000 people with MS in the study. And out of them, until March 2021, slightly more than 1,000 people with MS reported that they had COVID. Out of this 1,000 people, only 24 were hospitalized when they had COVID. And this is important to know when interpreting our findings, and also when we read about other studies, other research. There are two separate populations that are being discussed by researchers. Obviously, some people with COVID have a severe disease. They get admitted to the hospital. They might end up in ITU. They might need some help for their breathing. And it is very reasonable to think that those could be affected differently compared to people whose COVID is treated at their home in the community. And the population that we have studied are those people, are mostly people who didn't have a complicated acute infection, were treated at home, so they didn't have a severe baseline disease. So out of those people, almost 600 people were followed up, and they updated us on their recovery process. And again, a unique aspect of our study was that we did this prospectively. So what does that mean? It means that when people reported that I've developed COVID, we just kept asking them every 2 weeks, how you're feeling now, have you recovered? And we kept doing this until they reported their recovery. And we think that this is a more accurate way of estimating the duration of symptoms, COVID symptoms, when you start with people at the point that they had the infection and just follow them up in real time, rather than, for example, a year later asking, remember when you had COVID 6 months ago, how long did your disease last? There is a risk that if you do that, if you ask people retrospectively, depending on the severity of their symptoms, they might overestimate or underestimate the duration of their symptoms. So we think that this is a better way of estimating the duration of disease and therefore assessing long COVID. So when we did this, we found that at least 31% of our study population had persistent symptoms for 4 weeks or more, and 13% had symptoms, ongoing symptoms, for 12 weeks or more. That's more than 3 months. And we didn't have another population from the general population, from people who didn't have MS to compare them with. But fortunately, a study published in Nature Medicine, and you might be familiar with the COVID symptoms app study, they ran a very similar study in the general population, and they have reported that 13% of people in the general population have symptoms for more than 4 weeks, and only 2% have symptoms for 12 weeks or more. So what you can see is that people with MS seem to have, so a higher proportion, more people with MS seem to have long COVID, no matter how you define it, compared to the general population. And it is possible that this is not specific to MS. It is possible that other neurological conditions will show similar features. And yes, of course, as we said, MS has many symptoms similar to long COVID. So there is a possibility that when they had the infection, their previous symptoms got worse, and therefore we are seeing this higher rate. But again, no matter how we define it, we see that people with a neurological condition are disproportionately affected by long COVID compared to the general population, and this can have implications in their rehabilitation and how we provide care for that. So then one main question was, okay, within this population, in people with MS, which features predict recovery from COVID-19, or to put it another way, who is likely to develop long COVID? So researchers really like to use graphs and numbers. So first, before I show any results, I'm just going to explain what the graph will mean. So when we want to look at predictors of an outcome, in this case, our outcome is recovery from COVID-19. Again, we like to use something called the hazard ratio. And the hazard ratio, how we define it is we say whether it's 1, more than 1, or less than 1, as you can see on the y-axis here. Okay, so if the hazard ratio for any of these factors listed on the left is 1, it means that it doesn't have any association with recovery from COVID-19. It means that it doesn't affect recovery from COVID. It doesn't affect having or not having long COVID. If it's more than 1, in this case, it means that the specific factor with a hazard ratio of more than 1, so it means that it's on the right side of this line, that factor favors recovery. So if you have that factor, you're more likely to recover faster from COVID-19. And if it's less than 1, is on the left side of this vertical line, it means that the factor predisposes you to developing long COVID. Okay, so having said that, I'll start with the 3 demographic factors: age, gender, and ethnicity here. So as you can see, in our population, the hazard ratio for older age is resting on 1 exactly. So in our population, we couldn't find a relationship between age and long COVID. However, some other studies, not every study, but some other studies have suggested that older age could be a risk factor for long COVID. And because our population is people with MS, and they tend to be generally younger than the average general population, that's probably why we didn't find an association. So as you can see, when we looked at compared women to men, we found that the hazard ratio with this line falls below 1, and that means women are more likely to have long COVID. And this is in line with several other studies in the general population. When we looked at ethnicity, it seemed that, well, people, so again, a disclaimer, in our population, we didn't have many people from ethnic backgrounds other than white, and that was why we could only group them in either white ethnicity and all other ethnicity, and we couldn't look at other ethnicities in details because the numbers were so small. And when we compare that, as you can see, the line crosses 1. So again, from a research study perspective, when it crosses 1, we cannot say for sure that there is an association between ethnicity and long COVID. So further research with which larger numbers are required to exactly say whether there is an association or not. So the next thing we looked at was neurological disability, and we used some scores in MS to measure neurological physical disability in people, and we have grouped them in 5 groups. Group 1 is people with the least amount of neurological impairment, and group 5 is the people with the most severe scores of neurological impairment, and those are people who are restricted to a wheelchair or bed. So when we looked at the relationship between physical disability and long COVID, and all the groups are compared to the first group, and that's why the first group is 1, because when compared to itself, it doesn't increase or decrease the risk of long COVID. And as you can see, as disability gets worse, this square moves towards 0, that's less than 1. So people with higher levels of physical disability, with higher levels of neurological impairment due to MS are more likely to have long COVID. And again, it is possible that this is seen, although I haven't seen any other studies with other neurological conditions, but it's possible that people with neurological disabilities due to other conditions would be more likely to develop long COVID as well. But then again, we need further research into this. And another interesting thing that we found, we had access to levels of anxiety and depression before COVID. So we know who in our population probably had anxiety or depression before COVID-19. And when we looked at that, we realized that also having anxiety or depression before COVID increased the risk of developing long COVID. So as a summary, women, people with higher levels of neurological disability, and people with anxiety or depression before developing COVID seem to be more likely to develop long COVID. So this was our research, but when we looked at other studies in the general population, there were other potential long COVID risk factors as well. One of them was asthma. There was a study that suggested if people have more than 5 symptoms when they develop acute COVID, they're more likely to have long COVID. If they've had a more severe disease, potentially they would, it is more likely that they would have long COVID, and this was people who required some kind of hospital assessment during their acute infection. Being overweight or obese, smoking, being deprived, and poor general health were other putative risk factors for long COVID. So in summary, and what I think might be relevant to Headway is to know that people who have neurological conditions affecting the brain can be at increased risk of long COVID compared to the general population. And if they have higher levels of disability, physical disability, or have mental health problems beforehand, this can also increase their risk. And some references that you might find useful.
That's a problem. As soon as you get the doctors there, they talk and they talk, and then they never stop, isn't it? The intention was, to have a 5-10 minutes presentation from each one of us, and thank you, Afagh. So.
Well, I think everyone will join me in saying thank you to you both for that really insightful and really educational talk on COVID. Does anybody have any questions? I'm going to go through the screens and see if anybody's got their hand up or... I think we've got one. Somebody's just put it in the chat. Would you like to switch your microphone on and show your question? No?
There was no question. I was just thanking for the presentation.
Oh, thank you very much. Andrew.
Andrew, you're muted.
Hello, Nikos. How are you? It's been a while. It was just a question. Sorry?
It's a small world.
It certainly is. I know. We just run into each other. So is there any sort of evidence, or have there been in any studies into whether this is actually causing damage to brain tissue, or whether it's visible, say, on maybe high resolution MRI scans? In the same way we're seeing on the bowel biopsy, but I appreciate a brain biopsy is a different thing entirely.
So it hasn't been shown yet. And having said that, there are two big studies trying to look on the effect of COVID and long COVID with fancy. So we have the standard MRI scanners. The MRI scanner is the big tunnels you get in, and there are a few scanners that they are even more powerful, and you can see ideally a few more details. And people who were speculating, like Andrew is doing that. Who knows? We might be able to see it if we have a better machine. So far, nobody has shown it. Occasionally, it's not like a brain tumor or a stroke, or that you can see clearly there is a signal. Occasionally, what you need to do is you need to take, 50 scans, and you need to average them from people with long COVID and 50 scans with people that do not have long COVID. And when you compare them, you say, oh, there is a bit of a difference. So occasionally the difference is so small, it doesn't mean that it doesn't cause symptoms, that you only pick it up if you do lots of studies. And I know there's a big study that's going on in the States, and actually Nottingham will be participating, exactly the same question that Andrew is asking, and some other studies. So the only other study that I know, so when a few people have died and they look at the brain and they couldn't find anything obvious and gross. As I said, there is this study that will be published, has not been published yet, who says that, if we look at the molecular signals from some of the cells, as if they have been affected by COVID virus, but I cannot prove it. So it's a bit of an interesting thing. I don't want to jump to the conclusion that certainly there is a virus there in people with long COVID, but people are certainly looking for it.
Thank you.
Thanks, Andrew. Does anybody else have any questions? I'm just going to whiz through again and see. No? Okay.
Ali's there.
Yeah, sorry, I've been like, hi, nice to meet you. Thank you very much. It's brilliant. I've just had an email from a colleague from one of the Headway groups who's got child wrangling duty, so she's got to disappear. But she'd like to know your opinion on the role of Headway groups in supporting people with long COVID.
I mean, this is something that you will excuse me because, of course, I didn't know, and Tamsin was trying to explain to me that there are obviously some groups that they have a lot of strength, and some people, they're very organized, they have funding, and some people not funding. Long COVID is a serious condition, and these are people that they have developed the symptoms after the COVID. Asthma is a serious condition, and this is something that appears to be affecting the brain as well as other parts of the body. So if, ideally, the NHS should be providing expert support and rehabilitation services in all the people with chronic conditions, whether it is a brain condition or whether it's a lung condition. And now we have some conditions like long COVID that spans the different systems. Now, I would have said, again, without knowing, and Tamsi will stop me there, if I had the ability and I had the ability to supporting people that they have some cognitive problems, very similar to people that will have a head injury, but in addition, they have breathing. And if I have the ability to do it, I would have loved to do it. If on the other hand, you say, what are you talking about, doc? I have 500 people with head injuries and strokes that I cannot look after this, then, how thin do you spread? And this is where, you know better, how thin. So I can see the justification of helping, but accepting that, it's something that you might spread slightly outside of your expertise for the non-cognitive aspects. So if somebody comes along and says, oh, my breathlessness, I was predominantly affected by breathlessness, I have long COVID. So you could argue we will try to help people on predominant cognitive elements of COVID. And if your main disability is because of muscle aches or breathing difficulties, then, how can I help you? Nikos making it up now.
Thank you. We've had a question from Vicky. Will your study keep monitoring those who have taken part, I suppose on a longer term basis? And also, are there any ongoing studies within neurology and long COVID that you know of or are part of?
Yes, you caught me there. So there are studies that the neurologists, they immediately try to study the simple things. And the simple things is, have I had a stroke? If I have had a stroke, a week after I developed COVID. So there are a couple of studies that they have looked into and say that these are the problems that people have developed soon after COVID, and it's relatively easy. And the long-term studies, what we call the longitudinal studies, are a bit more, takes a bit more effort. And certainly the study that we're doing in multiple sclerosis will continue to collect data. But there are some big UK studies of looking at patients that have been admitted to hospital, what happens to them afterwards. So many of those, 10%, 15%, they will develop long COVID. So we'll have big numbers on that side. And there are some long COVID studies that they're just starting now. So there are studies, and because there are big studies, some of them are aiming at thousands of people, a proportion of them will be neurological, and we will get a bit of a good signal, I think, from them. And to answer the other question about people that they have experienced neuro symptoms for the first time in their lives, yes, I think Afagh's study is specifically for multiple sclerosis, that they have had neurological symptoms, but the majority of long COVID, when they're describing that I have a brain fog similar, as I said, to the things that you hear every day in your interaction, they did not have it before. They had the COVID and they developed it. So that's certainly the case.
Great, thank you very much. Any other questions from anyone? Put it in the chat function or just raise your hand. Oh, Greg Dean, would you like to share your question?
Guess this question to Nikos. Now, I might be off the mark here a little bit.
There's nothing off the mark.
I'm, as a brain injury survivor myself, I'm quite interested in the role that inflammation occurs within brain injuries, be it through hemorrhage or stroke or physical injury. Inflammation response is implicated as having an issue. And I seem to recall in the early days when they were looking at sort of the more severe cases of COVID, the inflammatory response was quite a key marker of what was going on and a very overactive immune response. Is there any link with that through to the long COVID stuff?
So we haven't found the link yet. I'm not saying that there isn't a link, but we haven't found the link. So one of the studies have looked at what was your blood test, how abnormal your blood test was when you developed the COVID. And they didn't find the people that have had the abnormal blood test are the ones that develop long COVID. And the problem is that there are many, many diseases that we see in the brain that when you take a blood test, it picks up, because there is this barrier between the brain and the rest of the body.
Yeah.
It picks up the peripheral inflammation. So there can be lots of inflammation. People with multiple sclerosis, classic inflammatory condition of the brain. If you do the blood test, all of them come back as normal. So, there isn't any inflammation, there isn't anything else. If you do a lumbar puncture, a spinal tap, you put a needle into the fluid and you take the fluid close to the brain, sometimes you see the inflammation. So this is the difficulty bit, is that the fact that people have said, oh, I can do a blood test here and, oh, I don't find any inflammation, so it's not an inflammatory condition. It's not necessarily reflecting what's happening in the brain. So some of the other ways that they're trying to work it out, but I don't know when we'll find the answer, is, so we know in our genetic makeup we have some signals that are influencing, some part of our DNA is influencing our immune response. So what they're trying to do now is they're trying to find out, like the chronic fatigue, is it that if you have this particular genetic makeup possibly related with immunity, with your immune cell, you react differently. So you might get your flu infection, the virus, I get the flu virus, one of us goes down with the same number of viruses, goes down for a month, and the other one the next day plays football. Who knows why, but we haven't figured it out yet.
Because it's quite interesting, because one of the risk factors was being female, and that with immune response would then correlate.
Yes, I mean that's absolutely true. And the other, I mean, we have there is a lot of this debate, and people with chronic fatigue, they know that very well, and we have had this debate. We're finding also that high levels of Afagh has found, and you can see who is the supervisor, the ones who does all the talking. Afagh does all the work and I do all the talking, So, Afagh has found that high levels of anxiety before the COVID was associated with long COVID. What does this mean? We're really struggling about this, because we know that there is a connection between high levels of anxiety and stroke, the collection of high levels of anxiety and ulcerative colitis, a number. So clearly conditions that we cannot say, oh, it's psychological. What is psychological? This, spectrum, what's psychological, what's the brain, it's all the same, but we're still struggling.
Thanks. That's both really interesting talks. Thank you both very much.
Thank you, Greg, for your question. I'll just quickly go through again. Does anybody have any questions? No. Okay, I'd just like to ask something. So it seems like the research is in really early days at the moment in terms of really establishing whether, you know, COVID is having a direct impact on the brain, whether we can, you know, consider it a neurological condition specifically. Could you sort of share a little bit about the research to date so far, specifically between a COVID infection and stroke and hemorrhages? Because there has been some research to date that I understand, you know, has found that certain people who have experienced quite serious COVID have gone on to develop strokes and hemorrhages, which could have an implication then on the number of service users that we might see in the future. And that's quite a clear, definite condition that we can identify related to COVID. So could you talk a little bit about that research, if you don't mind?
I would always talk, but you know, I can say that, oh, that's a difficult question. I can throw it to Afagh if she wants to answer, or I can answer it. Afagh, what do you think?
Yeah. So I'll answer what I know, and then you can add to it, of course. So about implications with long COVID, the care that provides. So it's a bit difficult to say, because we know that people, for example, someone who has a stroke for any reason will definitely have some rehabilitation needs afterwards. Anyone who is admitted to the hospital for any reason, even if it's not COVID, if they have a long hospital stay, if they're admitted to the ITU, they'll develop some cognitive problems, mental health problems, and physical symptoms and problems after their discharge. So there are so many confounding factors here, and to say exactly how much, when you have a stroke, for example, or hemorrhage after COVID, how much of the post discharge process, or even during the discharge, is because of the brain injury, is because of the hospital stay, how much of it is because of COVID, is very difficult.
The only thing to add, so what we know is that some people have had a terrible illness with a terrible admission to hospital. We know that there is stickiness of the blood, and we know that some people in the acute setting, they have had a stroke. So this is very well described. If you see the number of people, for example, that have had a stroke, they have a stroke every day because of our life, and the number that we can clearly blame COVID is, of course, a tiny number. So I don't think that you would be overwhelmed by direct COVID effect causing stroke or neurological conditions. The same applies. There's been all this excitement, and my life as on call during the last week is all these people have had the headache, and you know, half of the headaches happen after vaccinations. But of course, everybody's been vaccinated at the moment. So, you know, is it this terrible, this rare, very, very rare condition that some of the vaccinations. So the number of people who have the headaches is so common, you know, every day, that the vaccination is tiny. I think the problem that you will be having, is that at the moment, the hospitals are not functioning. So this is my complaint. The hospitals and the GP practices are not functioning. And to my mind, inappropriately is not functioning. You know, there is this very slow, you know, I have had demented people that they wanted to be diagnosed to have dementia, and they were told, oh, no, the memory clinic has a waiting list of a year. What? I mean, this is unacceptable. Having a telephone consultation. So I think the major problem that we are facing in neurology, in multiple sclerosis and headaches and strokes is of people not coming to hospitals, taking very, very cautiously in case not get infected. And at the same time, the collateral damage is even greater, I think, at this stage than the damage that people might have by coming to hospital. So we know one of the studies that we're trying to publish at the moment is that coming to the hospital, having an MRI scan, it doesn't really increase the risk of catching COVID. But there are still many, many people that they are afraid of coming to the hospital, and there are still the hospitals very reluctant. No, we don't want to see you because of the risk of giving you COVID. So I think this is the major problem. We need to get, the hospitals and the GP practices and the physiotherapists and the psychologists to start working again. And so if you can do anything of this, good luck. I'm with you.
Great, thank you. Any final questions from anyone? I'll just sit through again. No, okay. Well, I'll close up then, but thank you both again very, very much for your time and for all of that information. I hope everyone's found it useful and a helpful discussion to have. Just as a reminder, we will be making this available to watch over afterwards, so you can either contact me directly or I think we can make it available on our YouTube channel afterwards. I can send a link around following this. So unless anybody has any final closing comments, we can finish there. No? Lovely. All right. Thank you.
Lovely to see you all.
Thank you again and take care.
Take care.
Thank you.
Bye-bye.
Bye.